Hello everyone. Welcome to coding. As you can see, we are on week 9, chapter 11. Hello Gardner. How you doing, Kelsey? Kelsey, can you hear me? Can you hear me? Hello? Hello? Kelsey? Kelsey? Hello there. Hello? 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 Test, test, test. Test, test, test. Kelsey? 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 Hello? Hello, ladies.
I did some of it. I didn't do well on those chapters.
Yeah, really, it's so confusing.
Yeah,
Right?
I didn't understand how to do it, so I didn't want to.
Yeah, better we'll do it here.
Yeah.
You know,
Hello?
ninth chapter or what? We codes, we codes. Can we should do directly or we don't have to go index
Hello?
and regular?
I don't know.
Yeah.
I was confused about that.
Hello?
And really,
Hello?
we should do here. That's very important chapters. There you go.
Hello?
Hi.
Okay, thank you. Can you see me?
Yes.
All right. How's everyone tonight?
Yeah, good.
Good.
So we're on chapter 11, right?
Yep.
Okay. Let me get my glasses and stuff. Hold on.
Ninth adding, I was doing ninth one, but I don't know what I'm not sure that I'm doing good, correct.
Yeah.
Ninth and did you do ninth and tenth? Just
Yeah, I did some of them, but
can we go start here and do it? Ask her to do it.
yeah,
Ninth and tenth.
yeah.
Because here,
I
this
still
is also still confusing.
I know.
Index, okay, tabular. V codes and where are these
But then you
codes?
still have to double everything.
Yeah, where are these codes are? Yeah, guidelines.
Mm-hmm. and I still don't understand which one you're supposed to code first. I don't, the first diagnosis.
Oh, that is like a main term, etiology and manifest. Etiology, right? Like main term, anatomy.
But
main term.
With
Yeah, that's what we have to do. Difference.
With these exercises, how do you know
the symptoms? Like etiology. It's like main term and anatomy. Same as, I guess, so I had to ask her.
But if you have more than one thing wrong with the person, the doctor's note, I don't understand which one to choose.
Yeah. And
code.
here they're saying sometimes acute, but there's no acute here.
No.
Acute in this. Acute sometimes you don't find. And I think we have to do it here. Otherwise,
Right.
if you do at home and then come here and you all the things what to ask for.
Yeah.
Where is the etiology? Oh, it's here. Sorry, where I was reading. And these codes, like, where are these codes? I didn't find it here. These codes.
Right.
This one, it's okay. These codes. Where are they?
I don't know.
Yeah, that's what it's looking. Where are they? V codes, E codes, okay. And then in the middle of this will come. That's in between table, in between index. These are the things will come.
Yeah.
When we should go for this, and when we should go for this. Oh, E codes. These are E codes. Yeah, what is the difference between these E codes, and this E codes here?
I don't know.
Somewhere here, E codes.
Yeah, all the way to that.
What is between those and this? Etiology, manifestation, main and anatomy. In the beginning, in the other book, we learned about main term. We should look for main term and then anatomy. Same as here, we are learning same thing as etiology and manifestation.
Yeah.
Etiology is like symptoms, right? Even main term is like symptom. Same, are they same? I have tons of questions. I don't know whether she is. See here, when I went to V code, there are V code. When you're looking for V codes, where you have to look for everything, right? Where is it?
I know. I don't know how to look those up properly.
Yeah, because they don't have index. Because you have to go through everything. Like, see, when I was doing this vaccination, I was looking for vaccination. Then I don't know whether it's correct or not. And they're asking index location. Is this the index location? What they mean? Yeah, means just will ask her.
Yeah.
I think 9 and 10 is very important.
Yeah. I know, because I hate moving on
So
when
that
I'm
way,
not getting
if
it.
you're thorough with this, then good. Otherwise, if you go,
Yeah, because then we'll be like 3 behind.
and also, we can't come with her that way. And these are 1 to 8. Only 2, 3, 4 are not 3, 4. It's not going to.
I think 1 through 8 here.
Oh, 1 to 8. Chapters want to go. Oh, these chapters. Yeah. These chapters want to. Oh, yes. See, like the chapter. Oh, yeah. Chapter specific coding. Oh, those are chapter specific coding. Yeah. We'll first 8, 9, and 9 and 10, and then go for left. Because these 2 chapters you can practice, then you will be, if you're good enough, you can, that means you're good enough for this coding.
Right.
These are very, very important. I was going through today morning, oh my God, I couldn't concentrate.
All right, ladies. So let's first get out of the way classes, because it's my understanding that as of June 3rd, the adult ed will not be open. So, Kelsey, I talked to Jamie in the office and she said you were already aware of that. Is that correct?
Yeah, I am also aware I could not communicate with her. Means Evolve, no, what is Zabber? Through Zabber, we are going to attend, or
Say that again.
no, to Zabber, we are going to attend, or just how it is.
You mean like online or
Yeah,
a different
online
location?
or location, yeah.
Okay,
Is there
so
any other location like in Augusta? Can we go
No.
there? No, you can't go.
no. So if you have a Jabber account and you can log in from home.
Mm-hmm.
Do
I
both of you
haven't
have
set
it?
up at, yeah.
Okay.
Yeah, I didn't set it up.
Okay. So why don't you try setting that up
Yeah.
by next class so
Yes.
that we can and then if we have to test it, so I would suggest don't use a wireless. Make sure you're hardwired.
Okay.
Okay, so make sure your computer is plugged into the internet. Don't use a wireless. You'll notice that when Kelly comes on, when Kelly is not actually going to be joining us using Jabber anymore because she's using her laptop and she's using a wireless connection, so she's constantly getting kicked off. So it is hardwired is better, and you follow the instructions in your course guideline and it shows you how to set up your Jabber account. And then when you set up your Jabber account, send me your Jabber name so that I can log into the scheduler and add your name so that it will call you.
Okay. Yeah.
What happens is at 5:25, you need to be sitting at your computer and logged into your computer into Jabber. You sign into Jabber, and then the scheduler from Network Maine calls all the people who are scheduled to attend that session. So when you get a call, a little pop-up box will show up on your screen and you just click answer and you'll join just like you do here in class. Okay?
I'll try next week.
So just try it. And if you have any problems, just call Jamie or Amy in the office and they'll be happy to help you.
Okay. Yeah.
Okay? So June 3rd is going to be the last live class. The rest will all be done using Jabber. So because of that, let's see, I want to try and get an idea of where we are at with the course. So we are on week 9. All right, today is week 9. All right. 3. So, 13. If we go without any breaks, we will be done by August 12th. Okay, Did either of you have any vacation time scheduled in there?
No.
No, but can we do start from next week 6 o'clock? Like no,
Well, then we'd go to 9.
or yeah, but 6 to 8:30 it's not possible. 6 to 8:30 is not possible, or
Really, we're supposed to have 3-hour classes.
yeah, yeah. Nine is
So
okay.
how do you feel about that, Kelsey?
Well, my issue is if I'm going to be home with my son, then it's going to be a lot harder. I'll still have somebody there to watch him, but he'll know where I am.
Yeah.
6 o'clock, starting later would probably be better. But I guess that's up to you, because then it would go to 9.
Right. Right. Anita, are you just having trouble getting in for 5:30?
Yeah.
Okay.
6 will be good for me. So maybe next week.
How about 5:45?
Okay, that will. Okay, 15 minutes. Yeah.
We'll try 5:45.
Mm-hmm.
Okay. So next week we're still meeting in Gardner.
Okay.
Now, if I can finish in 2.5 hours, I will try to finish in 2.5 hours. But we're supposed to have 3-hour classes.
Yeah,
Now,
I don't want to rush it either.
Yeah, I don't want to rush it either. Absolutely. And so my thought for you, Kelsey, is even though you have someone there watching your son, are you able to go to like someone else's house? Okay.
No. Sorry.
All right. Well, from here on out, we'll just do our best, and if there's little snafus along the way, we'll make it work.
Okay.
Yeah.
All right. So by next week, get me your jabber names.
Yeah.
So what that ideally means then is that by middle of September, we want to be having our mock exam so that you can be ready for the national. So as we get closer to that, we'll talk more about it. Kelsey and Anita,
Is there anything? Sorry.
Nope, that's fine.
Is there anything in particular with the terminology book that we should focus on in order to do better with the exam?
No. You know the CPC exam review book that you have?
Yeah.
That we'll go through it when we get to the end.
Okay.
That will talk about the terminology and stuff.
All right.
Okay. But that's also where I've mentioned that if you have white space in your book and you know that there's certain terminology that might trip you up, you can use the blank pages in your books to make notes.
Oh, okay. It's good to know.
Yep. All right. So we are week 9, chapter 11 in our buck book. And for last week, you did 9 and 10. So you want to go over the answers? Did you get all the homework done, both of you?
We both had trouble with it.
Okay, that's fine. Let's start with Chapter 9, the review and practical in the textbook. All right. So, true and false. What do you have for number 1, Kelsey?
False.
Yes. Number 2, Anita?
Oh, I did exercises. I did exercises.
Okay.
Wait. False.
It's actually true.
True.
Number 2 is true. All right.
Why? It's post-operative diagnosis means
After surgery.
Sorry, I yawned. Okay. Number 3, Kelsey?
True.
Yes. 4 is true. Anita, number 5?
yeah, in the I'm not getting sorry.
Okay. 5 is false. 6 is false. 7, Kelsey?
True.
Yes. 8 is false. 9 is false. And 10 is false. All right. Did you try looking up the codes on page 267?
Well, the looking up the codes part, it's actually, the issue I'm having is I don't know, like when you have multiple things in the doctor's notes, I still don't understand what the diagnosis and the first thing to be coded should be.
Okay. And that's what we're going to learn. Okay. So, in number 11, what is the reason that the patient is coming in?
number 11.
267.
Oh,
I'm sorry, practical chapter 9. What page is it for you?
269.
Okay, 269, sorry.
These ones I tried. I don't know if they're right or not. We'll find out.
All right, so initial office visit for diaper rash. Why is the patient coming in?
for rash.
What kind of rash?
Diaper rash.
Okay, so what did you come up with for a code?
691.0.
That's correct.
Before going, can we? I did some of the stuff here. I have a few questions.
Yeah.
Like in the beginning, exercises 9-5, like V codes.
Okay.
V codes we should directly quote them, or we have to go to index, tabular, then V codes.
Index. Remember, in the V codes, it's going to be in your index, and then you go in the tabular to confirm it. So you go into the index. Remember, the V codes are going to be based on certain categories. So you would look up look it up in the index based on the category, and then go into your tabular to confirm the V code. So which one did you have trouble with?
I did, like I thought that V code will be coded directly into going into the V. Because
No, you're supposed to look it up in the index first.
like a small, see here a person who has been in contact with smallpox. We have to go smallpox.
You go to contact first. You go to contact and then smallpox.
Okay. Can we do next week 9 and 10? Next week is fine. These exercises, let me. I haven't done it.
Oh, well, these are the ones. The theory and practical is what we're doing now.
Oh. Since I did not understand this one, so I stopped there. I didn't go further.
Okay. So
I did
on
some
page
exercises in 9.9.3, like exercise 9.1, 9.2, and 9.3, 9.4.
Okay.
Then I started with the V code. I thought I was trying to code directly V codes. Not because it's not like they just asked V code directly.
Right. But if you look in your book, in the V code section in your textbook, there's a title called Index Locations. I don't know what page it is for you. It's going to be before exercise 9.5, and it's going to be under the V code category. It's after 9.4 exercises and before 9.5.
Yeah,
and it says index locations. So when you see these types of words in your exercise, in order to find the V code in the index, you're going to head to these parts of the index and then into your tabular. So they're giving you references here of what words would trigger you to look up a V code. Now, yes, you could probably start with smallpox. I'm not sure where it would get you. We can try that. But you always want to start in the index, the alphabetic index. Always, always, always. So yes, if we look up smallpox, we can get the answer, because underneath smallpox on page 465 in your ICD-9 book, right in the middle column, 465, middle column, smallpox, and then contact, V, 01.3. So then you would go to the V code section in your tabular and confirm that is the correct code. And where would you find it in the index location?
Page 1008.
There you go. And if you went to page 162 in the index, you would also find under contact smallpox. So when they're asking you the index location, they want to know what page in your index did you find this information. So you could have found it under smallpox, or you could have found it under contact. So you could have found it on page 162 or 465. And then what was the code?
V01.3.
1.2, yeah. So we should go for contact and then smallpox. First contact.
Huh?
First we have to go to contact.
Yeah.
Then smallpox. Then we.
Yeah.
Okay, does that help, Anita?
Yeah, I got.
Okay. All right, so Anita, do you have a separate piece of paper or notebook?
Paper, it's fine.
Okay, so this is what I do in my classes. If someone doesn't do the assignment, they can write the answers down on a separate piece of paper so that they can check the answers afterwards. I don't recommend that you write them in the book, because obviously then you're not going to have, you're going to have it right there. So, Kelsey, do you have an extra sheet or two you could give Anita, please? All right, so page 269, the chapter 9 practical. So then what did you have for number 12, Kelsey?
I put dyspnea and lower extremity edema.
Edema, yep.
And 782.3.
Okay, so let's look at this one. This is where an established patient presents with dyspnea and lower extremity edema. The physician determined that the patient's symptoms were due to an exacerbation of congestive heart failure. All right, so due to. When they talk about something being due to, that is usually going to be what you're going to start looking at. So even though the patient presented with dyspnea and lower extremity edema, it was because of the exacerbation. So the dyspnea and edema are symptoms of the congestive heart failure. So what we're actually going to code here is the congestive heart failure. All right, so why don't you take a moment and look up congestive heart failure.
So that's where getting confused. Dyspepsia and lower extremity, those are the symptoms, right? We have to go for etiology first and then manifest. And why are we going to congestive heart failure here?
What?
We always go for symptoms first, then anatomy, like.
Well.
But here we are going for congestive heart failure.
We're going to the congestive heart failure because the dyspnea and the edema are symptoms of the congestive heart failure. Mm-hmm. They're not causing the congestive heart failure. The congestive heart failure is causing the dyspnea and the edema. There's a difference there.
So they already diagnosed, so it's already diagnosed, so you just have to go for the direct one, not for symptoms.
you have to go directly to the congestive heart failure, yes. When you
That's
see
what.
the words due to,
Yeah.
it's pretty safe to say that you're going to be coding for what's after the due to.
Oh, okay. Because it's already diagnosed and that's okay.
So what did you come up with, Kelsey?
Well, I'm looking under failure. It says congestive, but see also failure at heart, and I'm trying to find heart right now.
Did you go to congestive?
No. Well, I went to failure first.
Go to congestive. Because this is what you want to think of. What type of failure is it? It's congestive. What type of? It's heart. So when you get to congestive, it's going to say see failure, heart. And then you can go straight to heart. All right.
Yeah, it's here and
Okay, so what does it tell you?
Congestive is like.
When you go to congestive, it tells you to see heart failure, heart, right?
Yeah.
Okay. And then when you go to heart, it tells you to see condition, right?
28. So it's saying heart C also failure and heart. So we have to see in index or tabular.
You stay in your index.
So I went to congestive, then it said go to congestion, and that said go to failure heart. So that's where I'm at now.
Okay, now go to heart.
And then do I leave it at that, or am I still looking for something else?
Okay, when you go to heart, it says what?
It says acute and sudden in parentheses, 428.9.
On what page are you on?
I'm on page 241.
All right, hold on.
See here failure. Can see here failure. Then where you
Okay, if you keep going,
okay. Then acute or sudden 420. You have to go for acute or sudden.
Well, then I don't know where to go.
so if you keep going down, you'll see congestive.
And then it says see also failure heart.
But then it says 428.0, right?
Right.
Okay, so do we have the words in there that we have in our exercise?
Congestive heart failure.
Heart failure. Okay, we do. So let's go to 428.0.
Congestive heart failure unspecified.
Okay, now, I think we learned this last week. You want to make sure that you read the before, the during, and the after, right? So we're going to go to the category 428.
Yeah.
And 428 says heart failure. Code, if applicable, heart failure due to hypertension first. We don't have hypertension in this exercise, right?
Right.
Okay. So then we go down and we read the excludes. What does it exclude? We don't have any of those, correct?
Yep.
Okay. So we go to 428.0. It tells us congestive heart failure unspecified. And this is unspecified. They didn't indicate anything more than just congestive heart failure. And they tell you what it excludes. We don't know if there's any fluid overload, so we can't use the excludes. But turn the page. And right at the top of the left-hand column, it says item 711, congestive heart failure, also known as CHF, is a condition in which the left ventricle of the heart cannot pump enough blood to the body flow from the heart, or the blood flow from the heart slows or returns to the heart from the venous system, backflow resulting in congestive fluid accumulation, particularly in the abdomen. Most commonly, fluid collects in the lungs and results in shortness of breath, especially when in a reclining position. Okay? So this is where I want you to learn to read the before, the middle, and the end. So even though it tells you a code, I want you to be familiar with what's the category. In this case, the category is the 428, which is the heart failure. Okay? Then underneath is where we get the congestive heart failure. So you won't have all of your words that you look up be this complicated. When it's related to a condition or a disease, it just might be. You might start off like you did, Kelsey, in failure, or you might start off with heart, or you might start off with congestion. Everyone starts a little differently. You still could have gotten to the same answer by looking at either one of those. It's just a matter of really drilling down, I call it, until you find that code. Does that make sense?
Yeah.
Anita?
Yeah, I got it.
Okay.
I had that problem when I diarrhea, then one more. See, also the same page, both referring to the same thing.
Right.
Yeah,
But that's what we learned over the last two classes, is when you have those references, you need to pay attention. All right, so number 12 is 428.0. All right, so number 13. Number 13, establish patient seen for management of vitamin B12 deficiency and hypertension. And what they're looking for here is what is the first listed diagnosis. And either one of these could be a first listed diagnosis. You could have hypertension first or vitamin B12 deficiency first. Either one would be correct. And what do you have for code for hypertension, Kelsey?
401.9.
Correct. What do you have for vitamin B12 deficiency?
266.2.
That is correct. All right. Number 13, you should have 401.9 for hypertension or 266.2 for vitamin B12 deficiency. Number 14, old anterior cruciate ligament tear. So the patient was admitted as an outpatient for an arthroscopic knee procedure to repair old anterior cruciate ligament tear. That would be 717.83. Number 15, we have syncope and diabetes mellitus. The syncope would be 780.2. The diabetes would be 250.00. 16, the patient was admitted for pain management following biopsy of the kidney for stage 4 chronic kidney disease. Postoperative pain is the first code, 338.18. Stage 4 kidney disease, 585.4. (17) Preoperative exam for emphysema, carotid stenosis, single. We have 2 codes here. The first one, 433.10 with V72.82, and then emphysema 492.8. So the first 2 codes, 433.10, V72.82, and then emphysema 492.8. All right, number 18, bladder cancer, 188.9. The postoperative diagnosis of bladder cancer is the reason for the hematuria, and it is the more definitive diagnosis. Number 19, what do you have for the main term, or the term that you would look up, number 19, Kelsey?
Exposure.
Yes, exposure. Anissa, what do you think, number 20? What word?
Polyps.
It would be history. Remember, we're looking at V codes. It would be history.
Yes.
And then number 21 would be status. So number 19, you would have a code V15.84. Number 20, V12.72. And 21, V42.1. How did you do, Kelsey?
Not as bad as I thought. I can find the code. It's just figuring out which one to list first
Okay, well,
for the diagnosis.
we're only in week 9, ladies. Okay, so don't freak out too quickly. You're gonna get it. Okay? It's gonna take practice, and that's what we're here to do, is to learn and practice. And the only way we're going to learn is by the mistakes that we make. Okay?
Yep.
So let's move on to chapter 10, theory and practical. What page is your theory, chapter 10?
287.
Thank you. All right. So number 1, list 2 of the 4 cooperating parties that agree on coding principles. What do you have listed there, Kelsey?
AHA and CMS.
Yes, and then you also have AHEMA and NCHS. AHEMA and NCHS. All right, number 2, you should have 2A, term or terms. 2B, the number 2. 2C, subterms. 2D, cross-reference. 2E, 2 and 1. 2F, tabular. 2G, specificity. And 2H, elements. All right, 3. 3 is D. 4 is true. 5 is false. 6 is false. 7 is false. 8 is true. 9 is true. 10 is true. Now let's go on to the practical. What do you think would be 2 common symptoms that are associated with kidney stones? Anita?
Pain and difficulty urination.
Yes. Some other ones might be hematuria, pyorrhea, dysuria, oliguria, abdominal distension, nausea, vomiting, fever, and chills. How about number 12, Kelsey?
Fever, shortness of breath.
Yes. Chills, chest pain, mucus production. All right. 13. Now, remember we talked about this in our lecture last week about acute and chronic, right? What gets coded first?
Acute.
Acute. So, Kelsey, what do you have for acute prostatitis?
I don't have these ones, but I start with prostatitis.
Yep, start with prostatitis, both of you. Prostatitis.
Here. Acute 601. 601.0.
Okay, what's that for?
For acute.
Okay, and what's the second code?
601.1.
Chronic.
Yes, that is correct. All right, let's do the next one. Number 14. Headache, stiff neck, and fever due to viral meningitis. All right, so what is headache, stiff neck, and fever? What are those considered?
Symptoms.
Right, so we're not going to look those up, right?
Right.
What are we going to look at?
For viral.
The meningitis.
Yes.
And what kind of meningitis?
Viral.
Right, so start with meningitis first.
So is it 047.9?
It is. Now remember, don't code from your index. I'll let you do it for right now, but always refer to your tabular, okay?
0.47, right?
047.9.
9, yeah. Can I just take this card?
Yep, just step out. Okay, you got it?
Yeah.
Okay.
I'm looking for 15 now.
Okay, good. So what did you look up first? Pyelonephritis?
Yeah.
Very good. We're on 15 now, Anita.
Okay.
So because it doesn't specify anything, it just says acute or chronic, or acute and chronic.
Right.
How do I know which additional digit to use?
Well, the first one is acute. Always acute first. What page are you on?
858 to 859.
It's acute 590.10. And chronic, right? 590. 590. This is here. First we had to this one.
Yeah, for number 15.
Then we had to go for that one.
Yeah.
See also. Oh, see also pyelitis.
Okay. In this instance, I'm going to tell you to assume that it is without a lesion.
Okay.
Okay. So that's how we would code it, without the lesion, because if it were something more severe, they should definitely specify it. And then we would know to code with, with lesion.
Yeah. So 590.10 and 590.00.
Correct.
So you don't have to go for pyelitis here. The C also pyelitis. The same. So this is one.
Well, because it's acute.
Yeah, acute and chronic. But here they say C also pyelitis. Right.
I can't hear you.
Like under pyelitis, they also said C also pyelitis. Under pyelonephritis, then C also pyelitis.
What? Okay.
It was just so
What page are you on?
just above pyelonephritis. There's a pyelitis. So which one to code? This or that?
Pyelonephritis.
Or
Pyelonephritis.
we don't have to go for pyelitis. C also pyelitis.
No.
Because it's already here, acute and chronic, so you don't have to go further.
Right. Okay, what do you have for number 16?
575. 575.0.
Nope.
Cholecystitis, acute.
You're close.
Okay.
575.12.
That is correct. And did we code abdominal pain?
Yeah, 575. Okay.
No. We do not code abdominal pain because it is
Oh,
a...
because that's just a symptom.
Yeah.
That's right. Correct.
I probably would have looked all night.
All right. How about 17? What are you going to look up there?
Infection? No.
Yes. Yes. Don't guess. Don't second guess yourself. Infection. What kind of infection?
UTI.
Yes. So look up infection.
Why is it now here there's a change? Because there's due to, it's already diagnosed, right?
What?
Here
Look up infection, urinary tract. And tell me what you find when you get to infection, urinary tract. Take it slow and read it carefully.
So because it's not elsewhere classified, it's just this one?
Which code?
599.0.
Correct. And then what other code? Because if you look at 599.0, you have excludes and then use additional code to identify organism. So you need to identify the organism.
Where is the urinary tract here?
So then we look up Proteus separately?
Yes. Yes. Proteus mirabilis.
What would that be under?
Infection. But it also gives you some codes right there, right? So what you could do is actually go to those codes 041.41, 041.41.
So did you say this one here?
So go to 041.
Where did you go again?
And then look it up back here.
From that one.
Page 679 in your tabular. Tell me if you find it.
Yes, 041.6.
Perfect. Got it. So, little lesson here is that because underneath infection it said code additional for type of bacteria, the organism. When it gives you the codes, just go directly to those codes. Don't worry about trying to find it in the index because you already know that it's Proteus mirabilis. All right, just scan through those codes real quick. Okay?
So then which code do we write in?
The 041.6. The first code you have is 599.0 for the urinary tract infection, and then the 041.6.
Oh, how did we get that? Here I got for 599. Then I went to tabular 599.0 urinary tract infection. Then Proteus mineral. How did you find?
If you look on page 862 underneath 599, it says use additional code to identify the organism, such as the E. coli, and then it gives you the code 041.41 through 041.49. So what my suggestion to you is that you go directly to those codes in your tabular on page 679, and you start looking for the code for the Proteus mirabilis. Got it, Anita?
Yeah. Yeah. Proteins. Yeah, I got 41. Oh yeah, here it is. 041.6. Proteins and mineral. 041.6.
041.6. All right, number 18, impending cerebrovascular accident. We're going to code starting with impending. $296 in your alphabetic index.
I looked up accident first before you said that, and it said to go to disease, or see also disease, but because impending was underneath it, I got that same code, so I didn't have to go to the see also. Is that correct?
Yes.
Okay.
But now I would like you to go impending first.
Yep.
So 435.9. 435.9.
I just want you to see that you can get it multiple ways. It's not always just one way.
Yeah.
Yeah, it's even in tabular it says 435.9.
What did you get for a code?
435.9.
9.
435.9, correct. All right, number
So
9.
one thing is sometimes you if there's a due to we have to select this or symptom. Which one means how to detect which one to select. This like if now here we are going for no if there is a due to I'm getting confused. This either sometimes we are going for diagnosis directly or symptoms. So
The urinary tract infection is what you're coding. And the urinary tract infection is happening because of the organism. So the urinary tract infection is the diagnosis.
Oh, okay. Sorry, what? Can I take this one?
Yep, just step out. All right, so 19, Kelsey, I'm just going to give you the answers for the last 3 if you want to write them somewhere else.
Yeah.
19 is 716.13 with 905.2. What I want you to pay attention to here for number 19 is that we are coding for the arthritis. And why are we coding for the arthritis? Because that is what the patient is presenting with. What type of arthritis is it? It's traumatic. What part of the body is it happening to? It's to the wrist. And why is this happening? Because the patient had a fracture 5 years ago. So not only are we coding what they presented with, but we're coding the late effect. Does that make sense?
Okay. Yeah.
All right. Number 20 is the dysphagia due to previous cerebral vascular accident. Okay, so dysphagia is a late effect of the CVA. And we would code here the late effect of the CVA, which is 438.82. But then we would also code the dysphagia, which is 787.20. And you will see that there is an instructional note that tells you to assign an additional code for that dysphagia.
Okay.
On number 21, respiratory, what is the code for respiratory syncytial virus, otherwise known as RSV? It would be 079.6. You want to make a note that the condition is in the ICD-9 index under respiratory, not virus. So when you're looking this up, it falls under respiratory, not virus.
Okay.
All right. And let's move on to the workbook. Did you do any of the workbook?
I did, yeah.
Okay.
I did all of them. Yeah, I did the true and false.
Okay.
No practical.
All right, so we'll just write the answers on paper, okay?
Yeah.
Let me just grab my book. All right, so chapter 9 in your workbook. Number 1, true. 2 is true. 3 is false. 4 and 5 are false. 6 is true. 7 is false. 8 is true. 9 and 10 are true. All right. Practical. 11, V18.19. We're in our workbook now, Anita, on chapter 9. believe it's page 49. Is that correct, Kelsey?
Yes.
All right. So number 12. V54.89. V72.0 for 13. $14 is V45.01. $15 V73.4. $16 V76.51. $17 V71.89. $18 V15.07. $19 V04.1. $20 V55.3. $21 V77.6. $22 V77.99. $23 V06.4. $24 V02.4. $25 V59.3. $26 V01.5. $27 V55.3. and $28 V53.31. All right, let's go on to chapter 10. Number 1 is false. Two is true. 3 is false. 4 is true. 5 is true. 6, 7, 8, 9 are false. And 10 is true. All right, on the practical. You only needed to list 2 common symptoms for 11 and 12. So any 2 of the following: urgency, burning pain, inability to fully empty bladder, lower abdominal pain, chills, fever, nausea, vomiting. For 11 and 12, any 2 of those. All right, for number 13, severe intellectual disability due to previous viral encephalitis. What would you consider to be the residual here? What do you think, Kelsey?
Intellectual disabilities.
Yes. So go ahead and look that code up. Disabilities, intellectual, severe.
318.1.
318.1, that is correct. All right, so we know that the cause would be the viral encephalitis. And the viral encephalitis happens to be a late effect. So find the code for the encephalitis.
So here they said when I went to tabular, it's unspecified intellectual disability. Do we have to see under that?
Encephalitis?
Oh, this. Yeah, here. See, when I saw disability, then intellectual, right? Then they said it's 319. Then when I went here, 318. Yeah, 319.
So what did you get for a code?
Yeah, it's 319 says unspecified intellectual disability.
No.
No.
The first code for the residual is 318.1. Now we're looking up the encephalitis, which is viral.
So this says excludes late effects of viral encephalitis. Does that mean 049.9 is not correct?
Correct.
So 139.0.
Yes, you got it.
No, it's under disability. Yeah, I saw intellectual. It's 319. Oh, again we had to go index.
Yeah.
I went to it. Okay. 319.
Okay, so 13, you should have residual 318.1 and cause 139.0. All right, so number 14, non-union of left tibia fracture closed.
Doreen, just 1 second. I got stuck in here. Intellectual 319, right? So we had to go for tabular, right? This intellectual 319.
Right, but it says severe.
Oh.
So you go to 318.1
318.
to check.
318. Oh, severe intellectual disability. Okay. Then.
So that means that's the correct code.
Oh, this is the one.
Yeah.
Yeah, you don't have to see this like viral encephalitis.
Right, because this is the first code right here, and then the viral encephalitis is the cause. So then you have to look up the other code.
Then go for viral and then encephalitis.
No, encephalitis and then viral.
Right. Okay. Yeah, I got it. Sorry.
All right, so number 14, non-union of left tibia fracture closed. What's the residual?
Non-union.
Non-union. So code the residual for me. What are we going to start with?
Fracture.
Yep, fracture or non-union. Try it either way.
Do we have to include left tibia in any way for the code?
No.
Okay. So 733.82.
Yes. 733.82, that is correct. All right, and then for the cause, what is the cause?
The fracture of the tibia.
Yes, the late effect fracture, a fracture of the lower extremity. So look up that code.
Yeah, here it's left.
Upper end or extremity, is that what I look at?
Fracture extremity lower. You start in late effects.
So it's 823.00.
No. Late effects fracture extremity lower.
And
.821.20.
No. One moment. All right, turn to page 325 in your alphabetic index. All right, so in the middle column, it starts with late effect, and then if we go down about midway, we see fracture. Late effect fracture.
905.4.
Yep, 905.4.
And there's no other notes, so it's that code.
That's it. So the residual is 733.82. The cause is 905.4. All right, so number 15.
why is that?
Number 15 and 16, I'm going to give you the codes. You can write them down. We'll move on because it's 7 o'clock and we've got to get through the chapter. 15, your residual code, you should have 733.00. Your cause code, 138. For number 16, The residual and cause code will be the 438.21. Number 17, 466.0 and 491.9. Number 18, 614.0, 614.1. Number 19, 590.10 and 041.49. Number 20, 008.63. Number 21, there's no code assigned because there's no code for impending respiratory failure and there's no other information given. Number 22, 458.9, and there is not going to be a code for threat and shock. Number 23, 482.2. Number 24, 034.0. And number 25, 710.0 and 581.81. Do I need to repeat any of those for you?
No.
Anita?
If you don't mind, can you send the email on all these answers?
Just remind me.
Okay.
Okay?
Mm-hmm.
All right. Let's take a quick 5 minutes here and come back and get done on chapter 11.
Okay. Did you do the exercises for chapter 11?
Yeah. No, she's
We're supposed to do it when we read the chapter.
no, we didn't do.
No, I know beforehand.
Oh, okay.
I feel like she's frustrated with us. But I'm not, I just didn't get it.
I remember sometimes this, sometimes that. See, we have now this cause fracture and tibia, right? But how do you know that she went somewhere?
Oh, I know. She already knew that it was late effect. I didn't put that much to.
Oh, that's a late effect. How come?
Yeah.
Why it's not written here, late effect?
I know. So I guess just with practice is how she was able to determine that.
It's not a late effect here because it's not mentioned here, right? I'm just looking fracture on the tibia. So
yeah.
What is it?
I know. That's what I was looking under. But then that's why she went to page 325 and was looking under late effect. And then fracture. And then tibia.
Oh, because fracture is a late effect. No.
Well, fracture isn't. It's just a lot. I hate when the thing freezes so I can't see her.
My eyes, I have little, too much sight. I'm not able to see the small ones. It's taking time. This is so confusing. Left tibia fracture, but there is a late effect. It's not written. Non-union of left tibia fracture. It's not written.
I hope chapter 11 is better. I hope chapter 11 is better.
No, if we have to go and see, then this is what we get confused, right? Non-union left tibia fracture means I'm just see, this is where I'm getting confused. I'm putting like fracture under tibia. Okay, I got stuck. How come it's late effect? How do we go? How do we know?
I don't know.
I think 20.
Maybe because closed. It says closed.
Late.
I don't know.
Late and tibia or what?
Then you go
Fracture.
extremity lower.
No extremity lower. Oh, okay. And 9055. Lower, it's not, they're saying lower.
Yeah, low, because it says left tibia. Tibia is your leg bone, so it's going to be lower.
Yeah. Oh, in that way, you had to just think in that way, okay.
Right, I know, that's my part. I wouldn't have gotten that.
That's okay, that's fine, but we had to go here.
Right,
and
the
then
late effect.
Lower.
I wish that we could actually be in the same room as her.
Yeah, that's what, this is, this is ulna, not ulna, that's tibia. That's what here, tibia.
All right, ladies.
Hi.
Any final questions on 9 and 10? And Anything that still isn't clear?
When you did the 14, the cause fracture and tibia, you just know from experience that it's late effect?
Well, let's talk this one out then. Non-union of left tibia fracture, and it's closed. So when it's closed, it means that didn't break the skin. Okay.
Mm-hmm.
When it says non-union, what does non-union mean?
I don't know. Can I look it up?
Absolutely.
Probably should have done that first.
You are a 9 by 8. Like separated or separated?
Not really. Non-union is where something doesn't heal properly. It doesn't heal, it doesn't align well. It's like a misalignment of the bone. So they didn't go in and reset it. They might have done it manually. They might have, stretched a little bit. So a non-union means that the bone hasn't healed properly. And it hasn't healed properly from the fracture. So just that the first thing that comes to mind when you say fracture is, okay, something happened because of the fracture. Well, what happened? A non-union, meaning that the bone did not come together properly. It did not heal properly. It's like, you want things to be even end to end. But non-union means that the bone didn't come end to end. It might have slipped off a little bit. Or if the person was walking too much, maybe the bone didn't get to heal correctly, even though they might have had a boot or a cast or something. The union of the bone didn't come together end to end. So when you just even think of fracture, and they're saying or using it in an exercise, in this instance, I would say there's a late effect involved, especially when you're having non-union. Non-union is a late effect because they won't see it right away. They're going to have to take an x-ray. And protocol usually is about 6 to 8 weeks before they even take another x-ray. They'll wait that long from the initial set of x-rays to determine how is it healing, because if the patient can't come out of the boot or the cast, or when they do it, it's still painful and they're not walking right, then this is where that late effect would come in. Does that make sense?
Yeah. So maybe you can expect like non-union. Those are the terms like non-union and closed in somewhere with the fracture or something
Well,
like that.
closed is the type of fracture.
Mm-hmm.
Closed simply means that it didn't break the skin.
Okay. Yeah.
So had it not said union, then you wouldn't have gone to late effect. You would have just gone to fracture.
Right.
Okay.
So in that case, you just have to go for fracture and tibia. That's it.
If it doesn't,
Right.
if
it says union. Oh, okay.
What you want to remember with late effects is that there's usually been an injury to a cerebrovascular accident.
Hello?
You can write down and show others.
Well, we can't hear her.
We can write down in that. Is that yours?
No, it isn't right now.
Oh, we got stuck in these two just.
Hopefully she can see it.
If we understand in these chapters, then we may not have problems. With the ICD, same as ICD 10 is more difficult because 7 digits.
Yeah. I think it's more consolidated though.
Yeah. And we are not going for tablet rule. Sometimes we are just coding from here.
I know. Well, no.
We have to,
We have to remember to look
just
at the other
yeah.
ones. Yeah. I don't know what to do. We can't even see her. I wonder if I have her phone.
Is that the question?
Let's call her. Yeah, it's the what do you call it? The syllabus.
Oh, syllabus.
For this, are you taking terminology too?
No.
We have this for that one. Hi, Doreen. The screen is frozen and we can't hear you at all. Yeah. Do you want us to just shut it off and then have you call in again? Okay. Bye. Okay.
Yeah, that's what you need to understand is nowhere they have given this term. Did they give in the book? Or while we were going into this book, maybe they must have given this in theory. But not in chapter 10. Did they mention anywhere non-union?
Oh, no, I don't think so.
Hi Ben, this is Doreen with the coding class. How are you?
No, we can hear.
Good.
No, we can
Okay,
hear.
now they can hear me. We were having trouble with the coding class hearing me. But I didn't know if something happened in your neck of the woods. Okay. You girls can hear me okay now?
Yeah.
Okay. So then we're good. Thank you, Ben. You too. Bye. All right. I have no idea. Can you? All right. And that's loud enough?
Yeah.
Yeah.
So we were talking about non-union, fracture, how to know that it's a late effect. So really trying to understand late effect. And basically a late effect is really anything that comes from an injury or accident. If you can remember that, you'll be good. Does that help?
Yeah.
Okay. All right. So chapter 11. What's the first page in your textbook?
290.
All right, 290 in your textbook. And this is where you're going to turn to your ICD-9 book and your guidelines. On page 8, you'll see that page 8 in your guidelines on the right-hand column, bottom right-hand column, we talk about chapter-specific coding guidelines. And this is what chapter 11 is all about. It is your chapter-specific guidelines. And we're going to be covering chapters 1 through 8. So I don't know how much we'll get through tonight, but we will do our best. All right. We start off in our book, as you know, in the coding, with infectious and parasitic diseases. And what you want to pay attention to with multiple coding on page 290 in your textbook is how is the sequencing? And we kind of ran into it already when we did that urinary tract infection due to, remember that one?
Yes.
So you want to sequence what first? You want to sequence the etiology first, and then the organism. So 599.0 is for the UTI, and then 041.4, I think it was 1 or 6. And 041 ends up being the secondary code only. So whenever you're coding the organism, it will be a secondary code. So when we talk about multiple coding, it's going to apply when there takes more than one code to describe the condition. And you have some examples right in your book on page 290. So what you want to understand in chapter 11 and 12 is to follow your guidelines, okay? So as I mentioned last week, when you see guidelines in your textbook, I want you to have your ICD-9 book available. I want you to follow those guidelines in your ICD-9 book. Now, I sent you pictures of the tabbing. Did you get those?
Yes.
No, I
Were
didn't
those
get
helpful?
it. I didn't get those.
Okay. So in your email to me for the answers, Tell me that you need the tabbing pictures too, okay? I also took some pictures of how I highlighted and underlined. Did you get those, Kelsey?
Yeah, I did.
Were you able to read them?
Yeah.
Okay. Do you think those will be helpful?
Yes, I do.
Okay. So, under Chapter 1 in your ICD-9 book, we start off with coding HIV. And HIV-related So what you want to do is only code confirmed cases. You only want to code HIV confirmed cases. So you see the guidelines right in your book, page 291. You always want to confirm the diagnosis and only code the confirmed diagnosis. So if you follow along in your ICD-9 book and your guidelines, you'll see right there, number 1, code only confirmed cases. And if it is an HIV-related illness, again, only code it if it is confirmed in the diagnostic statement. Over on page 9 in your guidelines, number 2, selection and sequencing of HIV. If the patient is admitted for HIV-related condition, the principal diagnosis code should be 042. Why? Because they're being admitted for HIV or HIV-related illness. V08. V08 is the asymptomatic HIV infection. This is to be applied when the patient, without any documentation of symptoms, is listed as HIV positive or known HIV test positive or similar terminology. Letter E on page 9 in your ICD-9 book. When a patient is being tested, you would code 795.71. Once the patient has a definitive diagnosis, you would not code it with V08. So you only code confirmed diagnosis of HIV. If they are being tested for HIV, you will code the 795.71 to indicate that it's a nonspecific HIV serology. If they are asymptomatic, you would code V08. Once they have been given that diagnosis of HIV, you would no longer code V08, you would code 042. So far, so good?
Yeah.
Okay. All right, letter F in your guidelines. Code prior diagnosis of HIV-related disease 042. When you are selecting,
do you have all these codes in somewhere here in index and tabular?
I'm not sure what your question is.
Do you have these codes in index and tabular?
Yes, they are in there.
Chapter
Yes.
specific.
No, the guidelines will only be in the guidelines section. You will have the little green boxes throughout the tabular that might give you a little snippet of the guideline, but not the whole guideline.
Okay.
So it will be important for you to know where to come back to the guidelines for this information. Okay?
Yes.
So what I'm pointing out to you here is not that you have to highlight or underline everything in these paragraphs, but just like on letter F, okay? What you want to take away from letter F is that once the patient has developed HIV illness, they should always be assigned 042 on every subsequent admission and encounter. That's what you want to take away from letter F. Once a patient has developed an HIV-related illness, the patient should always be assigned code 042 on every subsequent admission and encounter. Okay, so let's just say that a patient is admitted for injuries that are resulting from a car crash. And while they're undergoing treatment, just listen to this. It's not in your guidelines there. While they undergo treatment, the HIV-related illness, such as pneumonia, is diagnosed. How do you think we would code the sequence here?
You would still code 042 first, right?
Well, how did they present?
They're in there because pneumonia due to HIV.
Actually, they had a car crash.
Oh.
So they came in first because they had a car crash. But then while they were being treated, it was found that they had pneumonia. So we would code the car crash first and then code the HIV, followed by the related condition, which would be the pneumonia.
Okay.
Okay? And that would be right underneath 2B, patient with HIV disease admitted for unrelated condition. Two B, page 9 on your ICD-9 guidelines.
Yeah.
Okay, so right in that first paragraph, you would code the unrelated condition for the nature of the code, and then there's HIV, and then any related conditions.
Okay.
All right. What you always want to try to remember is the reason for the encounter. That's what you're going to start with, the reason for the encounter. So let's try this again. If the patient goes to the physician for a sore throat and happens to be HIV positive, would you code the sore throat first or second?
So first.
First.
Yes. All right. HIV,
So what if they went in and had well, what's a symptom of HIV? I'm sure there's lots of them. But what if they went in because of one of those symptoms, like pneumonia? Then you would you code HIV first because that's a symptom of HIV?
Yes.
Okay.
Yeah. All right, let's talk about HIV and pregnancy. Letter G. There is an exception to HIV sequencing here. And you're going to find that a lot throughout your guidelines, that there are exceptions. Okay, so during pregnancy and childbirth, if a patient is admitted for presenting for a healthcare encounter because of the HIV-related illness, they should receive the principal diagnosis code of 647.6, which is other specified infections and parasitic diseases. Then it would be followed by the HIV, which is the stated diagnosis. And then any HIV-related illness. Because in this instance, with childbirth and pregnancy, your Chapter 15 codes are going to take precedence here. If your patient is asymptomatic, they're going to be admitted for their healthcare encounter. And then during the pregnancy, they'll also receive the 647 code and the asymptomatic code. So again, a person can be pregnant, still not confirmed whether or not they have HIV, so they would have the V08 code. So if a patient has an inconclusive testing, what is the code that we're going to use?
VO8.
VO8, and then we're also for the test, it's going to be 795.71. So letter E, patients with inconclusive HIV, serology, 795.71. All right, encounters for testing for HIV. Code V73.89, if the patient is being seen to determine his or her status. So encounters for HIV testing, code V73.89, if they are coming in to determine their status. Use V69.5 as a secondary code if the patient is asymptomatic, but it is in a known risk group for HIV. And then V65.44 is going to be a counseling code. This is where the patient comes in and they get their results, whether they are positive or negative. If in fact they are positive, you will code 042 followed by the appropriate diagnosis. So you have a counseling code for checking the status, and you have a code for checking the status. The patient presents, they're checking their status, and that's the screening. And then when they come in for their results, there's a counseling code. Now, I do want to caution you that you do not want to incorrectly apply these HIV codes to a patient, because it can actually cause more hardship and harm by incorrectly putting information on claims that is not confirmed or accurate. Why do you think that is, Kelsey?
Upcoding. Upcoding or no? Upcoding or...
If you have more than one code, or if you have a wrong code, then it's going to be denied because it's not right.
Well, how would okay, what I'm trying to get at is that we have misdiagnosed a patient, and we have put on their health record that they have HIV and they don't.
And
So
once you put it on, it's always on there, right?
it is until you, unless it takes an act of Congress to get it off.
Oh, wow.
HIV is a pretty serious thing, and there are actually people who can request your health information if you allow it. And there's actually on a record release a paragraph that says you allow any information to be released that might indicate, HIV status. And, people get looked upon differently for having HIV. So if you incorrectly put a diagnosis on someone's health record, that is very serious, because it can be looked upon and they can be shunned for jobs or treated differently when they go into the doctor's office. So you have to be very careful that when you're putting codes on these claims, you're making sure that everything is accurate.
Mm-hmm.
Okay? All right, so let's turn to septicemia on page 10 in your ICD-9 book. And in your textbook, septicemia should be on, let's see, 301 maybe? Diseases of the blood and blood-forming organs.
Yeah.
But let's take a look. I want to make sure. All right, all I need to tell you about septicemia on page 10 in your ICD-9 book, right underneath number 1, SIRS, septicemia, and sepsis, you need to know that it's blood poisoning. So right beside that, to the left of it, I want you to write blood poisoning. So it's going to be important for you to know the correct definitions of the septic terms and how close they are in nature. So septicemia is infection in the blood, so blood poisoning. Septic shock is when the infection is so bad that the circulatory system starts to shut down. And SIRS, which is the systemic inflammatory response syndrome, is always going to be following the code for septic shock. When you hear sepsis, it refers to SIRS due to an infection. And severe sepsis is when an acute organ dysfunction. We would always code the septicemia first, and then the SIRS second. If it is documented septic shock, then it should be reported as such. When you have sepsis and septic shock associated with your OBGYN codes, you're also going to use codes from the ectopic and molar pregnancy category, and that would be your code 630 through 633. Keep in mind, though, your septic shock is never primary or first listed. For sepsis and severe sepsis that are not associated with non-infectious process, this is where you have an infection that is resulting from trauma or other serious injury. So when this happens, you would code that trauma and the injury first, and then the SIRS second, and then any acute organ dysfunction. When you have sepsis or severe sepsis, sequence the systemic infection and your sepsis codes before the non-infectious condition. So let's say someone came in from a severe car accident. We would code that trauma first, that injury. We would indicate that there is SIRS, and we would code any acute organ dysfunction. Could be kidney, liver, pancreas. Okay? Make sense so far?
Yeah.
Yeah.
All right. Let's turn to page 13 for neoplasm. Chapter 2, neoplasm. There are 2 steps for coding your neoplasms. You would first locate the type of neoplasm. Is it a sarcoma or a melanoma? Make sure you review all of the instructions. And then locate the code that's identified in your neoplasm table, which is usually by body site. So if you turn to your neoplasm table, page 351 in your ICD-9 book, you'll see that it runs by body site. And then across the top, we have the different columns. Malignant is first, with sub columns for primary, secondary, and carcinoma institute. And then we have benign, uncertain behavior, and unspecified. So in this chapter, it classifies the diseases according to the cause. Your neoplastic conditions will and can affect all parts of the body. So you would start in your alphabetic index under the neoplasm table, and then you would go into the tabular to find the code and confirm it. The M codes are used for inpatient settings. The M codes are used in the inpatient settings. These are what are called your morphology codes. This is Appendix A in the back of your book. So let's turn to Appendix A for a moment. Should be page 1075. All right, right at the top of page 1075, left-hand column, the very first sentence, the World Health Organization has published an adaptation of the International Classification of Diseases for Oncology. And then in parentheses, it has ICD-O. I want you to highlight that first 2 lines. This will actually be an answer to one of your questions. All right, let's go back to your guidelines. Page 13. Now, certain benign neoplasms may be found in specific body system chapters. So in order to properly code the neoplasm, it's going to be important for you to determine from the medical documentation whether the neoplasm is benign, in situ, malignant, or uncertain behavior. If it is malignant, any secondary site should also be determined. So if a patient comes in with a neoplasm, and it's the first listed diagnosis, and they're treating it for malignancy. So when they are receiving treatment directed at malignancy, letter A on the right-hand column of your ICD-9 book, the neoplasm is the first listed diagnosis, and then the treatment that they are receiving. If it happens to be chemotherapy or radiotherapy, you would code that treatment first and then the neoplasm. Why? Because the chemotherapy and the radiotherapy are the reasons for the encounter. They are presenting for chemotherapy or radiotherapy. And then you would list the diagnosis. Does that make sense?
Yeah.
All right. When we have surgical removal of the neoplasm and subsequent chemotherapy or radiotherapy, we would code the malignancy as the first listed diagnosis. If we have surgery to determine the extent of the malignancy, we would code that malignancy as the first listed diagnosis, and then we would code the neoplasm as long as the patient is receiving treatment or medication following the excision. What is an excision?
Removal?
Yes, removal. All right, page 14. Primary malignancy previously excised. This is where your V10 personal history of malignant neoplasm comes in. V10 can be used as a code regardless of whether a neoplasm was destroyed or removed. So a patient must be free of disease and no longer under any treatment for his or her cancer. This would include the chemotherapy and or radiation therapy. So V10 shows personal history of a malignant neoplasm. If the patient receives treatment for a secondary neoplasm, then you code the secondary neoplasm as the first listed diagnosis, even though the primary is known. So code the primary neoplasm as the secondary diagnosis, or if no longer treated, you would code personal history of. So let's just say cancer started in the lungs, okay? And it has metastasized to the brain, let's just say. And they find it on CAT scan or whatever, and they decide they're going to start treating that. So you would list the brain neoplasm as primary, because that's what they're working on, and then you would code the lungs. Okay, does that make sense?
It means like it came in first in lungs, right?
What?
No, it started in lungs, right?
Right. It started in the lungs, but it spread to the brain. But when they found that it spread to the brain, they decided they were going to treat the brain with chemotherapy or radiation or whatever, okay? Because it was treatable. So if the patient is coming in for treatment on the brain, that started in the lungs, it spread to the brain, they're treating the brain. They're going to make the brain the primary code and then the lungs.
Okay.
Because it's the reason they came in for the encounter.
Okay.
Okay?
Yep.
All right. Admission for symptoms of primary or secondary neoplasm. So, when we have symptoms and signs that cannot be used to replace the malignancy as the principal or first listed diagnosis. So, admission for symptoms of primary or secondary neoplasm, your malignancy will be your first listed diagnosis. The malignancy, not the signs or symptoms. You want to put the site that is receiving treatment as your first. So in my example to you, it would be the brain. That would be the first listed site receiving treatment. If they happen to be treating both the brain and the lungs, then you would code the primary being the lungs and then the brain. So if both the primary and the site that it spread to are being treated at the same time, you would code the primary first.
So had it started in the brain, then the primary would be the brain, right?
Right.
Okay.
Yes. I'm going a little slower with neoplasms because they can be confusing.
Yeah.
All right, so let's talk about a patient who is treated for anemia or dehydration due to neoplasm or therapy. What do you think we're going to code first?
The dehydration.
Or the anemia, yes. The dehydration or the anemia. Then what do we code?
Then neoplasm.
Right, the neoplasm, yes. Okay. What if a patient is admitted to repair complication of surgery for an intestinal malignancy? What are we going to code first?
Complication.
Yes, complication is the reason for the encounter, and then the malignancy is your secondary diagnosis. So you guys have it. All right. V codes and neoplasms. V codes and neoplasms. If a patient is receiving chemotherapy or radiotherapy post-op removal of a neoplasm, you are going to code the therapy first. Then you will code the active neoplasm that's still being treated. Do not report the history of neoplasm because it's not a history of yet. Because it just is post-op. It's not a history yet. It's only post-op. Okay?
Yeah.
All right, chapter 3. We're still on page 14 in the ICD-9 book in the guidelines. Chapter 3 is your endocrine system. This consists of the glands that are located throughout the body, and they are responsible for secreting the hormones into the bloodstream. So we should be on page 300 in your textbook. So some of the examples of endocrine disorders and diseases might be diabetes, goiters, hyperthyroidism, hypothyroidism, vitamin deficiencies, dehydration. What also falls under here is diabetes mellitus. This is the 250 code that is used frequently. So, page 14, chapter 3, endocrine nutritional, diabetes mellitus. There are subterms underneath 250 that often have two codes. For example, diabetic iritis. Diabetes is the etiology, right? It would be the cause. What is iritis? It's the manifestation. So we have a metabolic manifestation that would only have one code assignment, diabetic ketoacidosis. So you're going to have some subterms underneath your diabetes that has two codes, but you will also have some that only have one code, like the diabetic ketoacidosis. All right?
Yeah.
All right, on page 14, fifth digits for category 250. Page 14 in your ICD-9 book. Fifth digits for category 250. There are fifth digits that indicate the type of diabetes, whether or not it is adult or juvenile. And zero to 2 is your type 2. 1 to 3 is your type 1. I know also within your CPT book and ICD-9 book, they give you subclassifications for you to determine which code is correct. Your healthcare providers, your doctors, they should document the type of diabetes, including whether or not it is controlled or uncontrolled, because then you're coding on the basis of that information, and you need to make sure that the correct fifth digit is selected. So if you are just a patient who's receiving insulin, it does not mean that you are insulin dependent. It might be type 1 Type 1 patients will be insulin dependent because the pancreas does not produce enough insulin. Type 2 is non-insulin dependent, but you can still be on insulin. You might need it for a certain time period. If your diabetes is uncontrolled, it must be documented by the physician. The wording in the documentation can use out of control. You cannot assign uncontrolled status when the documentation states poorly controlled. So the doctor's notes have to be very clear. Is it out of control? Is it controlled? Make sure you pay attention to that. Your diabetes code will not indicate if the patient uses insulin or not. It has to be in the doctor's documentation. And if that is the case, you would use code V58.67 in addition to your diabetes code to indicate that they are long-term use of insulin. Now, even though diabetes is one of the most common endocrine disorders, there are many other disorders within this category, such as gout and dehydration, toxic diffuse goiter, and they can also be known by other names, such as Basedow's disease, Graves' disease, primary thyroid hyperplasia. And these are all things that would be indicated in the doctor's notes and findings. All right, Chapter 4, page 16, right-hand column of your ICD-9 book. These are diseases of blood and blood-forming organs. So we're probably on page, 301 in your textbook? Diseases of the blood and blood-forming organs. This is a short chapter. There are only 10 sections. It includes anemia, blood disorders, and coagulation defects. The most often used code here is for anemia. You have many types: hereditary hemolytic, iron deficiency, acquired hemolytic. You will find that multiple coding is often necessary, and you want to always identify the underlying disease condition. There are two confusing anemias. The first one is anemia of chronic disease and your chronic simple anemia. You're not going to find it in your textbook. They don't go into that much detail. The anemia of chronic disease will be a disease-causing anemia, such as my thought escaped me. To code for anemia, 285.2, and then the appropriate code for the chronic disease. Chronic simple anemia, you want to code the anemia first, 285.9, and then the chronic simple, 281.9. Your behavioral and neurodevelopment disorders. This would include your codes for personality disorders, stress disorders, neuroses, psychoses, intellectual disabilities. Your physician must be specific in their diagnostic statements and if they are not clear, you need to have them clarify them. You will also find that in this chapter, you will have fifth digit subclassification, probably 302 or 303 in your textbook. But fifth digit subclassification will indicate the status of the episode. So let's say, for example, 304 is your drug dependence. It has the following fifth digits, 0, 1, 2, and 3. 0 being unspecified, 1 continuous, 2 episodic, and 3 in remission. So again, pay attention to your fifth digit subclassifications. Chapter 6 on page 17 in your ICD-9 book is the diseases of the nervous system and your sensory organs. So probably 303 in your textbook. Chapter 6 will cover your central nervous system, the peripheral nervous system, the disorders of the eye and adnexa, and the diseases of the ear and the mastoid process. When you have pain not elsewhere classified, this is code 338. If it is acute or chronic due to trauma, post-op, neoplasm, psychosocial dysfunction, 338 is not for generalized or localized pain. It would be the first listed and the primary diagnosis if there is not a definitive diagnosis established. If pain management is the reason for the encounter and the admission, then that would be your diagnosis. All right, Chapter 7. Chapter 7 on page 19 in your ICD-9 book. This is the diseases of the heart and blood vessels. Hypertension is one of the most common conditions that you will find coded in this chapter. You have uncontrolled hypertension, and when you have uncontrolled hypertension, it is considered malignant. You have a hypertension table in your ICD-9 book. It's located in your index. You can also refer to figure 11-2 of your text. You'll see that it gives you a small indication of what the table looks like. The first category will identify the hypertensive condition. Is it accelerated, antepartum, cardiovascular disease, cardiorenal, and cerebrovascular disease? These are the first categories. Your remaining 3 columns will indicate, is it malignant, is it benign, or unspecified? So very similar to the neoplasm table that we saw earlier. With hypertension, you want to assign, is it arterial, essential, primary, systemic, or not elsewhere specified to 401. So if you look at figure 11-2 in your textbook, right at the very top line, it says hypertension, hypertensive. And then it has all of those words in parentheses. What are those called?
Essential. Essential.
They're modifiers. Yes, they're modifiers. So they help you to determine what type of code you're going to find. The 4th digit will indicate the type of hypertension. So always assign the appropriate 4th digit to indicate, is it malignant, is it benign, or is it unspecified. Do not use malignant or benign unless the documentation supports that designation. When we have hypertension with heart disease, hypertension with heart disease falls under the 402 category, and hypertensive heart disease refers to secondary effects on your heart that is prolonged, sustained, or systemic hypertension. Heart conditions are assigned to a code from 402 when there is a causal relationship stated, such as due to hypertension or implied hypertensive. You want to use your additional code from category 428 to identify the type of heart failure in those patients who present with heart failure. There may be more than one code from category 428 that might be assigned if the patient has systolic or diastolic failure and congestive heart failure. Your hypertensive chronic kidney disease. You want to assign codes from category 403. This is a cause and effect relationship that is assumed in the chronic kidney disease with hypertension. Why do you think that is, Kelsey? Cause and effect.
Because you have the hypertension with the chronic kidney disease.
Yes. So when you are coding these, make sure you have the correct fifth digit representing the renal failure stages 1 through 4, or the end-stage renal disease, stage 5. Always use an additional code to identify your stage of chronic kidney disease. When you have hypertensive heart and chronic kidney disease, you're going to use codes from category 404 when you have both hypertensive chronic kidney disease and hypertensive heart disease being stated. You want to assume the cause and effect relationship here and assign the fifth digit to mention the heart failure and or the kidney failure. What stage are they in, or is it end-stage renal disease? Also keep in mind that you use additional code from category 428 to identify the type of heart disease. And over on page 309, it gives you stages of chronic kidney disease and hypertension. When we have hypertensive cerebrovascular disease on page 20 in your ICD-9 book, hypertensive cerebrovascular disease, you want to code the cerebrovascular disease first and the type of hypertension second. Hypertensive retinopathy, what are we going to code first?
Hypertension.
The hypertensive retinopathy first, and then the type of hypertension. All right, if hypertension is secondary, that means that it's caused by an underlying condition. So code that underlying condition first, and then the type of hypertension second. Transient hypertension. Transient hypertension is a temporary elevation of blood pressure. You do not want to assign codes from the category 401 through 405. Your hypertension diagnosis is not established yet, so instead you would code an elevated blood pressure and then let's say transient hypertension of pregnancy. So what this tells me is that the patient's pregnant, she came in, she has an elevated blood pressure, she doesn't really have hypertension. So we're not going to code from the hypertension 404 codes. We're going to use 796.2. When we have controlled hypertension, this is usually done by therapy, and we would assign codes from 401 through 405. And again, you want your physician's notes to be very clear that it's controlled. How is it controlled? If it is uncontrolled, it means that we have untreated hypertension. Again, the doctor's notes should be clear that it's untreated, uncontrolled, and if that is the case, we're going to assign it a code from 401 through 405. For a patient who has elevated blood pressure, number 11, elevated blood pressure code 796.2. The patient would have elevated BP without hypertension being diagnosed. Again, if the hypertension is not stated, do not code to 401. What I'm going to do is stop here at this section. And we can finish it next week. What I want you to do for homework is to chapter 12. Chapter 12, you will read and do all the in-chapter exercises. Finish up the theory and practical on chapter 11 in the textbook and the workbook. And do the Evolve exams if you can.
Do you have 10 up there yet?
I do.
Okay.
I do. So, Kelsey, where do you live?
Litchfield.
Where's that?
10, 15 minutes from here. It's between Richmond and Gardner.
Okay, so I'm assuming Augusta is close for you?
Sort of.
Florida. And what
Yeah,
about
20
you?
minutes or so.
What about you, Anita?
Yeah, Augusta is close.
Okay. All right, homework. Chapter 11, finish up theory and practical, do the workbook, do the exams on Evolve, read chapter 12, do in-chapter exercises, and set up your jabber. Okay?
Yeah.
Any questions? What's your takeaway tonight, Kelsey?
Trying not to get overwhelmed and discouraged. I feel like I did really well with chapter 2 and 8, and then not so well with 9 and 10. So.
And that's going to happen.
Yeah.
Because we have a whole lot of information that you're not going to be able to remember it all. So the guidelines are going to be very important for us. Okay?
Yeah.
But you did really well looking up the code.
Thanks.
So don't put so much pressure on yourself right off the bat. How about you, Anita?
Good. Now I did understand few, whatever I had questions while doing. I was doing some of the homework back in at home. I had so many questions to ask. So now I'm okay there, but I'll see. And suppose if we are coding for this chapter, uh, like HIV, and just see only guidelines, or we had to go
You're
to
going
index.
to code in the alphabetic index and then go to the tabular.
Just this is just guidelines. Just
Those
you
are
don't.
just guidelines.
Yeah.
Those are just guidelines that tell you how you should code certain situations. So if you're ever questioning, how do I code someone with hypertensive retinopathy? If that guideline isn't clear for you in the tabular, then you know where to come back to it to confirm it. That's what the guidelines are for. It's a direction. It's where to go. Okay? All right. So, next week, same time, about 5:45.
Yeah.
Okay.
Oh, that's starting next week?
Yeah.
Yeah.
Next week.
Okay.
Okay. Can you
All
let
right.
Gardner know that next week you'll be in about 5:30?
Yeah.
Thank you.
Thank you.
Thank you.
All right. Have a good weekend.
You too.
Be safe. Take care.
Bye.
Bye.